Hello, my name is Dennis Connors, and I am presenting case study number 13, which is over bacterial pneumonia. So, for starters, what is bacterial pneumonia? So, bacterial pneumonia is an infection of the lower respiratory tract that is caused by various bacteriums. Pneumonia, with its various causes, accounts for over 45,000 deaths per year, and it is the second leading nosocomial infection in the United States, second only to urinary tract infections, or otherwise known as UTIs. The most common cause of community acquired bacterial pneumonia is the bacteria Streptococcus pneumoniae, and other bacterium that may be the causative agent in bacterial pneumonia include, but are not limited to, Legionella pneumophila, Moraxella catarrhalis, and Haemophilus influenzae. So, there are two types of bacterial pneumonia, two categories, and they are community acquired bacterial pneumonia and hospital acquired bacterial pneumonia. So, the most common cause of community acquired bacterial pneumonia is when there is a colonization of a bacterium in the upper respiratory tract, followed by aspiration of secretions containing the colonized bacterium. Another way for the community acquired bacterial pneumonia to be caused is by inhalation of certain bacterium after an already infected individual coughs, sneezes, or talks, releasing the bacterium into the air to be inhaled. Now, for hospital acquired bacterial pneumonia, a person can be infected in the same ways that one is infected with community acquired pneumonia. However, individuals can also acquire it through the use of respiratory aid devices such as BiPAPs and ventilators, and when a patient is intubated. These equipments can allow unwanted bacteriums to invade the lower respiratory tracts by bypassing all of the upper respiratory tract's natural defense mechanisms. Now, this is a chart that we can find actually in our advanced pathophysiology book. It is a pathophysiologic course of bacterial pneumonia. And so it starts with three causative agents, which is aspiration, inhalation, or hematogenous. And so what happens is the pathogens bypass upper respiratory defense mechanism, and they can go towards releasing toxins. But what will happen when those pathogens have been introduced to this lower tract? It'll be recognized and phagocytized by alveolar macrophages. Um, then what will happen is an inflammatory and immune response will kick in. Cytokines will be released. Neutrophils will infiltrate, and then we'll have immune complex deposition. What will happen is they'll have damage to the epithelial cells and alveolar capillary membranes. And so this is also a result of the toxins that are released by these pathogens. After this happens, exudation of fluid and cells will come into the alveoli. Ventilation perfusions will mismatch, and it'll result in hypoxemia. And so all of this works out to cause illness, respiratory distress, and more manifestations, which we'll see in this next slide. So, the clinical manifestations or the signs and symptoms that are common with bacterial pneumonia include the following, but are not limited to: fever, chills, a productive or dry cough, most of the time productive, a malaise, pleural pain, dyspnea, hemoptysis, inspiratory crackles and auscultation, tachycardia, tachypnea, and the list can go on and on. So, how do we evaluate and how do we treat bacterial pneumonia? And so, starting with evaluation, diagnosis of bacterial pneumonia is typically made based off the patient's presenting symptoms, physical assessment, and the patient's exposure to pathogens and the patient's history. The patient may need the following tests and imagings. So, starters, a white blood count will need to be drawn. And so, with a normal individual who is not immunocompromised, um, bacterial pneumonia may present with the white blood cell count being elevated over the normal limits, which is around 10,000. For someone that is immunocompromised, you may actually still see a lower white blood cell count. in those individuals. Then we may want a serum procalcitonin, which this can oftentimes be used to show somewhat of the severity of the damage and the illness of bacterial pneumonia. However, it doesn't really play a role in regards to what antibiotic we use for the patient, but it does help with knowing the severity of the illness itself. Next, we would want to take some sputum cultures or some blood cultures. That way, we can better understand what bacteria is actually causing it, and furthermore, be able to find the specific antibiotic that can help to get rid of this specific bacteria. Next, we would want a chest X-ray, as this can help us to rule out specific differential diagnoses, as well as kind of see the extent of the pneumonia and its damage. And so we'll talk a little bit about this a little bit later when we're talking about those differential diagnoses that can be related to bacterial pneumonia. Next, we'll talk about treatment. And so, treatment of bacterial pneumonia typically begins with establishing adequate ventilation and oxygenation, followed by broad spectrum antibiotics. And so, once a culture is grown, a bacteria specific antibiotic may replace or be added to the current antibiotic therapy. And so, obviously, we don't want to just wait until this culture is finished to begin antibiotics. You want to go ahead and jump on that so that we can go and hopefully start killing and getting rid of the bacteria that is causing the illness itself. And so, that is until we can get a specific antibiotic that can better attack whatever is affecting the individual. Now, if the patient is hospitalized, the patient may be placed on broad spectrum antibiotics that target and cover resistant bacteria such as MRSA. This is especially the case when you have a patient that has been intubated and on the ventilator, BiPAP, on some type of respiratory aid that is somewhat, if not completely, invasive. All right, so let's get to the case study. And so, again, case study 13, we're talking about bacterial pneumonia. This is kind of just a good generalization of the report given by the patient's caregiver. And so I'm going to read that to you guys now. So, Miss BI is an 84-year-old white female who is widowed and a retired bank manager. She owns her own home and has a 45-year-old female caregiver who lives in that home. Currently, Miss I uses a walker and takes daily strolls to the park with her caregiver. She is able to perform most activities of daily living. However, the caregiver prepares all meals. The patient presents to the clinic accompanied by her caregiver, who reports that Miss I has a 1 week history of upper respiratory symptoms and a 2-day history of increasing weakness and malaise. Approximately 3 days ago, the patient developed a cough that has gradually become worse, and she now has difficulty catching her breath. The caregiver also reports the patient was confused last night and nearly fell while going to the bathroom. The patient has began coughing up a significant amount of phlegm that is thick and green in color. She has, I can't read that right there. She has no fever. The caregiver has become concerned by the patient's reduction in daily activities and an inability to get rid of her cold. So there's a lot going on with this patient. And so what I have done is I have used the SOAP method to better organize and present the signs and symptoms, the complaints, and the histories and the objective information, as well as my assessment and plan for this patient. So I will present it as a SOAP note. And so, starting with the chief complaint, Miss I presents to the clinic with her caregiver, who reports that Miss I is, in quotations, confused and very sick, and was up most of the last night coughing. The caregiver also reports that Miss I has a 1 week history of upper respiratory symptoms, a 2-day history of increasing weakness and malaise, and a productive cough that has lasted 3 days and has gotten worse. Pertinent medical history includes tobacco dependence times 64 years, specifically cigarettes, chronic bronchitis times 13 years, urinary overflow incontinence times 10 years, hypertension times 6 years, mild level left hemiparesis caused by a CVA that was 4 years ago, depression times 2 years, constipation times 6 months, and she had her influenza vaccine times 3 months ago. So, continued subjective information includes family history, which is positive for hypertension and cancer. However, it is negative for coronary artery disease, asthma, and diabetes mellitus. A social history includes the patient lives with her caregiver in her home. She smokes about half a pack of cigarettes per day, and she has been exposed to some friends who are recently ill with the quotations cold. So, a review of systems includes it was somewhat difficult to assess due to the patient's lethargic mental status. The caregiver did state that the patient has had trouble sleeping due to persistent cough. Caregiver has not observed any episodes of emesis, but reports a decrease in appetite. And the caregiver denies dysphagia, rashes, and hemoptysis. So, for our objective information, a medication list has been presented. So, she takes atenolol, 100 milligrams by mouth every day, HCTZ, 25 milligrams by mouth every day, aspirin, 325 milligrams by mouth every day, nortriptyline, 75 milligrams by mouth every day, Combivent MDI, 2 puffs, which is 4 times a day, albuterol MDI, which is 2 puffs 4 times a day as needed, and then docusate calcium, 100 milligrams by mouth rectally. So, assessment. The patient's age appears to be consistent with that reported by the caregiver. She is well groomed and neat. She uses a walker for ambulation and walks with noticeable limp. She is a lethargic, frail, thin woman who is oriented to self only. The patient is also coughing and using accessory muscles to breathe. She is tachypneic and appears to be uncomfortable and moderate respiratory distress. Her vital signs are as follows. Blood pressure is 140/80. She has a pulse rate of 95 and it is regular rhythm. She has respiratory rate of 38 and it is labored. She has a temperature of 98.3 degrees Fahrenheit, and has an O2 saturation of 80%, 86% on room air. And so she's obviously in respiratory distress. That is something that we will want to address and address pretty quickly. And that's something we'll talk about in the assessment as well as the plan. But continued objective information. Her skin is warm to the touch and clammy without any rashes to be noted. Her HEENT includes the following: extraocular movement intact. She has pearless, her pupils are equal round, reactive to light, and they accommodate. Fundi are without lesions. Eyes are watery. Her nares slightly are flared with prurulent discharge visible. Ears with slight serous fluid behind the tympanic membranes. Pharynx is erythematous with purulent post-nasal drainage, mild bilateral cervical adenopathy. She has mucous membranes that are inflamed and moist. Her lungs and thorax, her breathing is labored with tachypnea. Her right upper lobe and her left upper lobe reveal regions of crackles and diminished lung sounds, with her right lower lobe and left lower lobe reveal absence of breath sounds and a dullness on percussion. Her cardiac assessment has a regular rate and rhythm with normal S1 and S2 heart sounds, but is negative for her S3 and S4 heart sounds. Her abdomen is soft and non-tender with normal active bowel sounds. Her musculoskeletal, she has extremities are warm with strength, rated at 4 out of 5 on the right side and 1 out of 5 on the left side, which could be related to her CVA, which was 4 years ago, but it also could be something that is new, and so we would obviously want to check that out. Our neuro is she's oriented to self only, which is it's just different than baseline from the presenting symptoms and the statements of the caregiver. Her cranial nerves 2 through 12, which are accessible, are intact. She's got deep tendon reflexes 2 plus on all of them. And she's got a normal Babinski reflex. So, continued objective information include lab blood test results, which I will not read every single one of them to you guys. But what is noteworthy is especially her white blood cell count, which is 15,200, which is elevated. And so we want to make sure we note that, especially. And so there is some sort of infection. Then we want to look at her ABG, so her arterial blood gases. And what we'll see is that she does have a normal pH. So let's go forward with that. Normal limits. We'll note her urinalysis, which for the most part is within normal limits. Nothing really too notable. Most things are negative. Everything seems to be within normal limits. Her chest X-ray shows that there's consolidation of inferior and superior segments of the right lower lobe and the left lower lobe. And it looks like for the upper lobes of the right and left, there's developing consolidation. She's negative for pleural effusions, and her heart size is within normal limits. She does have blood cultures that are already drawn. However, we are pending results. And so, assessment. So, based on Ms. I's objective and subjective presenting symptoms, it is clear that the patient is suffering from some sort of respiratory infection. And so, the primary differential diagnosis for this patient include, but are not limited to, respiratory failure, exaggeration of the patient's chronic bronchitis, and foreign body aspiration. The patient is obviously in respiratory distress, noted by her tachypnea and low oxygen saturation. Therefore, any of these diagnoses could make sense for Miss I. However, they don't all completely add up with the findings presented in this case study. For starters, respiratory failure would not paint the entire picture, as it does not explain the nasal drainage, high white blood cell count. It is something that would most likely be secondary to another diagnosis, as that would be something that would be happening as a result of something else, especially in this case where you can see obvious signs of infection, especially with her permanent discharge from her nose and whatnot, as well as some of the irritation that we see with her throat and whatnot. Next, the exaggeration of the patient's chronic bronchitis would also fail to explain the cause of the patient's symptoms that point to infection. Obviously, her chronic bronchitis has a lot to do with her respiratory distress. However, it's more of a byproduct of a underlying issue. Lastly, a foreign body aspiration is possible and could explain a lot of the symptoms that the patient is having. However, it is quickly ruled out by the x ray, which accounts for no foreign body. And so, bacterial pneumonia is the most likely diagnosis, as it is able to explain and give an account for all of the presenting symptoms of Miss I, including her high white blood cell count, her productive cough, her prudent nasal discharge, her respiratory distress, and the patient's confusion. So, what is our plan with this patient? So, based on the presenting signs and symptoms of Miss I, the first thing that we need to do is to ensure the patient has adequate ventilation and oxygen saturation. The patient will need to be placed on oxygen, starting most likely with via nasal cannula, and we'll titrate it to ensure an oxygen saturation of at least 90 plus. Due to the patient's confusion and respiratory distress, the patient will most likely be hospitalized for further treatment and management of her condition. During the patient's stay, the patient will be placed on a routine nebulizer treatment to assist with opening up her bronchioles. The patient will also be placed on a broad spectrum antibiotic while we await the blood culture results. The patient will also be placed on fluids to ensure hydration during her stay. And so, due to the patient's history of a CVA and new onset of confusion, which could be due to her respiratory distress and her bacterial pneumonia, and kind of the time frame that she's kind of been struggling with this, I would still also want to order a CT of her head to rule out any new infarct CVAs and any intracranial processes that could be causing her confusion. And so during this patient's stay, What we'll want from the patient is we want the patient to ambulate daily. So this could be with physical therapy, with PT, as tolerated. We want her to definitely use her incentive spirometry every hour while awake. We want to place her on fall precautions due to her weakness and her confusion and her lethargy, especially while she is there. She already walks in a walker, and so this makes sense to make sure that she's at least a standby assist, and that when she is moving, that she has someone with her to prevent her from causing any complications or injuries in that facet. Some complications that we can include with this patient with this plan is if the patient has any further confusion, if the patient does end up having a CVA on top of her bacterial pneumonia, that can make a tricky situation because we wouldn't know necessarily which symptoms are being caused by which diagnosis or disease process. What we could also see is if she does have a fall and does hit her head and does cause some type of bleed or trauma, that can also delay her not only her stay, but it could delay her from being discharged and being able to go home, and also being able to actually participate in her care as we try to get her better. If she does refuse to use the incentive spirometer, that could end with the result of atelectasis, so she could have a lung collapse, which would definitely increase the potential of mortality of her end up having dying while she's in the hospital, or if the antibiotic that we are using, or not necessarily the antibiotic, but if the bacterium that has infected her lungs and caused her bacterial pneumonia, if it is a resistant bacterium, we don't have a terrible amount of antibiotics that really can treat the resistant bacterium. And so, for the ones that we do, for example, vancomycin, we want to make sure that we prevent toxicity with giving too much, especially with her age. She could be very sensitive to that. And so, we want to make sure that we get those troughs um, and prevented her from having any complications with the medicine that is trying to help her. And so, with that, that is the case study 13 over bacterial pneumonia. And so, what I have included is my citations, and so the different resources that I did use for understanding this presentation as well as this case study. And so, obviously, if you have any questions, you can comment on it, and I appreciate your time and you guys listening to me. And so, thank you so much.